Assalamu alaikum. Let me welcome you on behalf of Ahsan Academy to a presentation on the heart. This is the second part of the presentation on the gross anatomy of heart. Let us fix the objective first for this session. We will discuss the structure of the wall of the heart. Then inside that there is conducting system of the heart that will be discussed, and at every stage we will try to correlate clinically. The heart comprises of several layers. If we consider the layers from inside outer, the first layer is endocardium, then is myocardium and epicardium. Look at the photographs. Now we'll consider the layers from outside. This bracket is indicating several layers of coverings of the heart. Of this, the innermost layer, this one is the epicardium. So outside layer is actually the innermost layer of the covering. The thicker part is the myocardium. This is comprising of muscle cells, and it is special type of cardiac muscles. And innermost layer, that is the endocardium. This is actually endothelium on connective tissue. Let us discuss one by one all the three layers. The innermost layer is endocardium. You can see the variation of the thickness. Endocardium is very thin and compared to the myocardium. The endocardium inside is the lining epithelium, which is simple squamous epithelium, and this simple squamous epithelium is known as endothelium. It is on a supportive layer of connective tissue that contains a few smooth muscle cells, and inside that we get a deeper connective tissue layer that is known as subendocardial layer of connective tissue. So total endocardium comprises of a lining epithelium, which is simple squamous epithelium, also known as endothelium, on a layer of connective tissue. Myocardium is primarily the cardiac muscle. It's a comprises of muscle cells that forms a tightly knit bundles of cells. They intermingle with each other, so crossing each other. I'll show some photographs. This is striated form of muscle cells. Skeletal muscle and cardiac muscles both are striated form, and each muscle cell is covered by a thin layer of connective tissue known as endomysium. That endomysium contains many thin capillaries, blood vessels, the minute blood vessels. When this connective tissue covers a bundle of muscles, it is known as perimysium. This becomes thicker, and this connective tissue is thickened further to form the skeleton of the heart. You see this nature of distribution of the muscles. Muscle fibers are directed in all the directions, forming a network-like structures. This is showing the directions of muscle fibers, and you can imagine the distribution. Connective tissue portion of the of the heart wall is not containing any muscle cells, so it cannot conduct the impulse from one place to another, and also cannot take part in the contraction process. This is spreads all throughout the walls, starting from the epicardium to endocardium. In a reverse way, you can say from inner layer to outer layer. All the layers contains these connective tissue contributions, and this is very thin between the cell intercellular space, and it is becoming thicker around the great vessels means and the orifices of the great vessels, and forming a complex geometrical pattern all over the heart. You see, it is making circle around the orifices and also spread all over the heart to form a net. It's a barrier to normal electrophysiological impulse that is transmitted by the cardiac muscle. This separates the atrial muscles from the ventricular muscles, so impulse from the atrial muscle cannot go to the ventricle through the cardiac muscles, and except one side through which the conducting system crosses. It provides area. It's a tougher sheet, so muscles are inserted into this sheet and can ensure a very forceful contraction process. This is supporting the valves present inside the different openings, means openings between atrium and ventricle, also opening of the great vessels into the chambers. So to these the valves are attached. The inside the valve, the connective tissue is there. That connective tissue is continuous with this one. So the valve has a strong supportive ring. Conducting tissue is the specialized portion within the valve. This is actually comprising of the cardiac muscles, but this has some special property that they can generate electrical impulse, so they can spontaneously contract, and when the electric impulse is discontinued they can spontaneously relax. So the component part of these is known as pacemaker tissue, who are the modified myocytes. Histologically different type of modified myocytes are visible. They are nodal cells, transitional cells, and the Purkinje cardiac myocytes. Their spontaneity in impulse generation varies. So some are having rate faster than the rest of the part. Conducting system of the heart comprises of SA node, means sinoatrial node, AV node, means atrioventricular node, AV bundle with its bundle branch, subendocardial plexus of ventricular conducting cell. These are also known as Purkinje cell or Purkinje fibers. So this each will be discussed subsequently. So SA node, a sinoatrial node, is a small crescentic shaped structure. It is located just deep to the endocardium at the junction of superior vena cava and right atrial valve. We know a elevation, sulcus terminalis, or inside, that is known as crista terminalis. This is situated in its upper part close to the opening of the superior vena cava. This is identified histologically by the presence of a large central artery. SA node initiates, regulates impulse of contraction of the heart, so it is known as pacemaker. As its rate is highest, it's about 70 times per minute, it supersedes all other impulse rate, so it dominates over the other parts of the contracting system. Sympathetic stimulation accelerates the rate of generation, and parasympathetic inhibits this rate. Atrioventricular node. This is relatively smaller than the SA node, and it is situated posterior inferior region of the interatrial septum. It is near the opening of the coronary sinus, and it can be identified by identifying the triangle of cause. It is in the floor of the triangle of cause. Previously we have discussed the triangle of cause, that it is a triangular area bounded by a tendon of Tourado, then opening of the coronary sinus, and the base of the tricuspid valve. Atrioventricular rate working as the conducting impulse generated by SA node, because its generating power is less than the generating power of SA node. So it's just simply conducting the SA node's power. Its conducting, its initiating of the impulse power rate is 40 to 60 per minute. Sympathetic stimulation increases the speed of contraction, and parasympathetic is reverse. Previously we have discussed that a connective tissue skeleton is there, and this fibrous skeleton separates the atrial muscle from the ventricular muscle. So conduction, electrical impulse cannot be conducted through the cardiac muscles because of this barrier. So this atrioventricular bundle is the only bridge of this barrier, and it passes through the skeleton. It enters into the membranous part of the intraventricular septum, where it divides into two bundle branches and enters into the muscular part of the ventricle. You can see the photographs. Atrioventricular bundle divides into right and left branches at the junction of the membranous and muscular part of the intraventricular septum. It proceeds in the muscular part of the intraventricular septum on either side, left one on the left side and right one on the right side, deep to the endocardium. It then divides into Purkinje fibers. Let us discuss the bundle branch. The right bundle branch is also known as right subendocardial branch. It is passing as a single branch just on the right side of the muscular part of the septum, and it enters into the moderator band. In the moderator band, through moderator band, it enters into the base of the papillary muscle, where it divides at every stage. It gives branches to the intraventricular septum, then papillary muscle, and then the wall of the ventricle. The left bundle branch divides very early at its beginning into about 6 small tracts, and separately they spread in the septum and in the wall of the ventricle. You can see in the figure. So it is giving branch to separately the intraventricular septum, papillary muscle, and the wall of the ventricles. Conducting system block is an important clinical condition. Most of the cases, the block become visible immediately if it occurs at the SA node level, AV node, or bundle level. But right bundle branch block is very common, and it is significant clinically because it is very common and the effect is not visible clinically. And only the patient appears when they are doing the normal ECG, and incidentally they are discovered as a case of right bundle branch block, or they land to the doctor with some symptoms. Thank you very much for remaining with the presentation.